Good evening. I almost said morning. Good evening, Endo Summit Live, and welcome to this final episode in our webinar series ahead of our 3-day conference this weekend. Joining us is Dr. Ken Cernovo from the Center for Endometriosis Care. Welcome, Dr. Cernovo.
Hello, how are you, Sally?
I'm doing good. Do you want to introduce yourself to everybody?
Sure. My name is Dr. Ken Cernovo. I'm the medical director at the Center for Endometriosis Care in Atlanta. I've been the director there for about 15 or 17 years. The Center for Endometriosis Care is a multidisciplinary center for the treatment of endometriosis. We've been in existence for about 35 years, and we've treated patients from about 80 countries and about 11,000 patients between the three doctors that have been there.
Incredible. And also joining us is the Endometriosis Summit co-founder, Dr. Andrea Vidali. Dr. Vidali, do you want to introduce yourself?
Good evening, everybody, and lovely to see you tonight. My name is Andrea Vidali. I'm a reproductive endocrinologist and immunologist, and also an endometriosis surgeon. And I'm very excited to be here with Dr. Cernovo tonight.
Yes, so we have a great live audience here on Facebook, YouTube, and LinkedIn. If you have questions, you can put them in the comments. If you're an attendee on our Zoom, you can put your questions in the Q&A. We do ask that you stick to theory and you don't ask about individual cases. So Dr. Cernovo, let's start with the basics. What is adenomyosis?
Okay, well, adenomyosis is endometrial tissue or endometrial-like tissue growing into the myometrium of the uterus. So really, the main part of the uterus has two components. You have the endometrium and the myometrium, and in between those is a basalis membrane or a basement membrane, which normally separates the two of those. And for some reason, there is a dysfunction between the endometrium, where the egg and embryo implant, and the myometrium, which allows the endometrium to grow into that tissue.
Yes, you said Dr. Vidali's favorite word, which is implant. So, Dr. Cernovo, we'll talk about him and his implantation later, but what are some of the symptoms of adenomyosis?
So a lot of the symptoms of adenomyosis are very similar to that of endometriosis as well. So patients often have heavy, clotty, crampy periods. Backache is very, very common in these women, and that often can be one of the worst symptoms that they have. They often have pain with intercourse that may last for hours or even days afterwards. And some of the patients may also have kind of cramping throughout the month as well.
Yes. So, docs, where do you begin with your evaluation when you are looking at adenomyosis, or when you're trying to figure out which is adeno and which is endometriosis?
Well, part of it has to do with the history. Do they have heavier bleeding? There's the idea that endometriosis alone causes a lot of heavy bleeding, when in reality, probably most of that heavier bleeding is from adenomyosis in those patients. So if you have someone who has a really strong history of heavy or long periods, that's usually a bit of a better sign of adenomyosis being the cause of that, especially if there's clots that are present. And then really it comes down to the physical exam and then either ultrasound or MRI evaluation as well of those patients. So on ultrasound, there's a whole bunch of different diagnostic criteria that we use to determine whether or not someone's got adenomyosis based on their ultrasound findings. So often the uterus is going to be more enlarged, and it's usually going to be what we call uniformly enlarged and without any discrete masses within the uterus, such as fibroids. So if you've got someone like an average size uterus is usually around 7 or 8 centimeters in size. So once you start getting a uterus that's closer to about 10 centimeters in size, then you start worrying about it. Often the thickness of the uterus is going to be greater in someone who has adenomyosis as well. So typically someone who doesn't have adenomyosis is probably going to have a uterus that's maybe 3 or 4 centimeters in thickness, but then with adenomyosis, you're going to get 5 or 6 centimeters in thickness, and it's also sometimes going to be broader. You're often going to see what we describe as a homogeneous, heterogeneous texture of the myometrium. So instead of it being kind of this uniform kind of gray, you're going to see these areas of white and darker areas with the adenomyotic uterus. And there's something called the junctional zone, which is the area between the endometrium and the myometrium, which is thicker in those patients who have adenomyosis as well. So with the MRI, you're going to have similar findings as well, but it's just basically looking at a different tool to kind of see those changes there. And then when you examine someone, when you're doing your exam, part of my exam is I always check the pelvic floor first to make sure they don't have pelvic floor dysfunction, which the pelvic physical therapist needs to address. But then we examine the uterus and the cervix itself to see whether they're particularly tender, and then looking for other features of endometriosis on the exam as well.
So Dr. Vidali, ultrasound or MRI, what do you think the advantages are of some and not the others? That was very extensive. I mean, I don't want to miss out on complimenting you on how amazing and extensive that was, Dr. Sorovo.
It's an important question, and I think that it depends very much, first of all, on the I would say both tools are adequate in determining the presence of adenomyosis. I would think that personally, I just like Ken, we do our ultrasounds in the office. We have access to that type of imaging, and I personally find ultrasound very reliable in diagnosis and adenomyosis. In fact, there are cases in which the MRI is negative, but the ultrasound may be more suggestive. So I think the two tests are complementary in a way. And sometimes if there's indecision, sometimes in some cases the ultrasound helps more or the MRI helps more. But I'd like to say that a lot less attention has been dedicated to the concept of the junctional zone. A lot of people don't worry as much about that principle, but and a lot more attention has been placed on certain patterns, that speckled patterns as visible on ultrasound, those little speckles that you see in the uterus, and so that's really one of the things. I do have one example of adenomyosis in MRI, but we could look at it a little bit later. But we have time. But I think that, like I said, I personally diagnose routinely adenomyosis on ultrasound, and sometimes the patient will be, "What? You're not doing an MRI?" And I'm like, "Well, I think that ultrasound is pretty reliable, and there's pretty much agreement on that." But this idea that I hear sometimes patients say, "Oh, you can only diagnose this with an MRI," I don't think it's accurate. I don't know how Ken feels about that, but I feel that you could both go either way.
Yeah, I think one of the biggest problems that I've run into since I've been doing a little bit more MRI for looking at bowel, the same problem exists when you're looking for adenomyosis. It really comes down to who's reading it. Mm-hmm. And if you have someone who's like an excellent radiologist, they're going to be able to tell you everything that's going on. But then you have someone who doesn't necessarily deal specifically with gynecologic pathology, and you're going to have someone who's, may not call it. And then there's other factors as well, such as have they been on hormonal suppression? How does that affect an MRI? And that's definitely a very important factor in, if you've been on a Mirena and you take it out and the next day you have an MRI, or you've been on Orlissa or Lupron, that's probably going to have a higher false negative rate compared to, someone who has been on suppression for a long period of time.
Yes, for people who are very interested in understanding why the junctional zone may or may not contribute to the adenomyosis diagnosis, we have a lovely video on our YouTube with Dr. Gargiulo, who has decided to join us this weekend. And you can watch that video and learn. He presented all the latest research on that. So, Dr. Cernovo, what are some of the things you talk to about patients regarding adenomyosis and how that diagnosis might and also we didn't establish, is it a diagnosis through ultrasound or do you need pathology?
Well, the only way to be 100% sure is with pathology. So you really have to go by the correlation between the clinical symptoms that the patient has and your findings on either ultrasound. I prefer ultrasound as well, just like Dr. Vidali does, or MRI. And then if you have things that are pointing towards that, we're between the MRI and the ultrasound and the clinical diagnosis, we're about 85 or 90% accurate in making that diagnosis. So then it's a matter of, how are we going to try to manage this? So in someone who isn't necessarily trying to get pregnant, then, the first line treatment is some form of hormonal suppression. Probably the thing that I think works best is Mirena, because it's a higher dose of progesterone in the Mirena compared to other IUDs. And I think that because it's acting more locally than systemically, like an oral birth control would or some other form of birth control, it has a greater impact on the uterus. And it's going to help with uterine pain a little bit more than, say, birth control would. And it may help decrease bleeding a little bit better than an oral birth control would. So that's kind of like the first treatment option of someone in the office if they're not trying to get pregnant. If we suspect that they also have endometriosis, which is extremely likely in those patients, I think adenomyosis by itself is definitely less common than adenomyosis and endometriosis together. And so usually they're going to have both of those things going on. By the time they've gotten to me, they've usually failed 3 or 4 birth controls already for their endometriosis. And then it's a matter of, okay, are they wanting to be conservative or are they wanting to be more aggressive? So conservative means wanting to keep all the reproductive organs. So what can we do to try to help with their pain, and what can we do to try and help with their bleeding? Those are the 2 things that we want to try to address. So usually that would involve the laparoscopy, where we're going in and cutting out or excising all the endometriosis that they have. And then rarely, if they have an adenomyoma, which is kind of like almost like a fibroid that's made out of adenomyosis instead, you can remove those, but those are much, much less common than what we describe as diffuse adenomyosis, where it's kind of intermixed between normal muscle and adenomyosis. And so often it involves a large portion of the uterus, and it's impossible to kind of treat all of that stuff, except when you've got really severe cases where the uterus is huge. You might be able to do some what we call cytoreductive surgery, where you try to eliminate some of the burden of the adenomyosis in the uterus. And then so what you can do is
jump the gun on my next question, which was
no, not cytoreduction.
No, but then we'll talk about it after. But we were getting to it.
Okay. Well, and then we try to manage their pain. Okay. There aren't a lot of ways to manage adenomyotic pain. Really, the only thing that we have from a conservative perspective is a presacral neurectomy, where we remove some of the nerves coming away from the uterus, which can help with uterine pain 70 to 75% of the time in the first year. And then probably by 5 years, it goes down to about 35% effectiveness. But that does have some other side effects, and there are certain patients that aren't good candidates for that as well. So some of the side effects that you see with the presacral neurectomy are constipation about 10 or 15%, decreased bladder sensation of about 5 to 8%, and then maybe lack of sensation of contractions when in labor. So they need more monitoring along the way when they're pregnant as well. And then to try to work with their bleeding. And again, the Mirena is probably the best option for that. But if they're trying to get pregnant, then you can't do that. Then you have to look at other things to try to maybe help them get pregnant as well, because infertility and increased pregnancy loss are other problems that you run into.
Yes, so that leads very well into this question. Dr. Vidali, adenomyosis and fertility. He could be here for 30 minutes of that one. But in general, adenomyosis and fertility.
Well, let's just say that, just like what Ken just said, I was in preparation for tonight's conference. I was looking at a recent meta-analysis, and which a meta-analysis is a study that combines many studies. So they sort of they group them together in order to look at the data in a little bit with bigger numbers. But in this recent meta-analysis, it was published this year, adenomyosis had a lower live birth rate in IVF patients of about 50%, half the live birth rate, and 66% of the clinical pregnancy rate, and twice the risk of miscarriage of people without adenomyosis. So it is a very significant impact on IVF. I mean, it's very non-negligible, and I just don't think that, in my opinion, that this, although I think people like, Dr. Sinerva or I are very aware of this, I think unless the adenomyosis is very significant, sometimes I even see IVF doctors not paying as much attention to it. I mean, because even a little bit of adenomyosis can have an impact, because it's not just a mechanical problem. And sometimes I've seen patients who've had literally hundreds of ultrasounds having IVF cycles. And I'm sure this has happened to you also, Ken, where they come in and they're like, why do you have to do one more ultrasound? I've had 1,000. And I'm like, well, let me take a look. And then I'm like, wait a second, you have adenomyosis. I'm sure this has happened to you too, right?
Oh,
Ken?
yeah. They're looking at different things. Most of the time they're looking at the ovaries,
Yeah,
they
look at
the thing that's carrying the pregnancy.
Yeah, it's I've had already 1,000 ultrasounds, and I'm like, well, wait, let us take a look with a different perspective, and you see that. But like I said, double the risk of miscarriages, half the chance of IVF implantation. This is not a joke. So it's a major impact in IVF outcome, and the real dilemma is what to do about it, right? Because this is really what Ken was alluding to, where we have, in a way, I hate to say this, but adenomyosis presents more of a challenge than endometriosis, in the sense that with endometriosis, at least with a proper excision, you can have a significant impact, but both on pain and fertility. But what are we doing both for pain, but what are we doing for fertility in terms of can we have an impact? And that's tough. That's tough because the data is not very, very clear. It's not very clear that, because Ken was alluding to hormonal suppression, that it does help pain, but it's not clear that hormonal suppression actually improves IVF outcomes. And this is really, although people do it because really it's the only thing you can try in a way, because, what else are you going to do? But it's not clear that the canonical 2 months of Lupron prior to embryo transfer actually increases pregnancy rates. It's still a matter of debate to some degree. Studies are not concordant, so.
And the improvement was not very big in those studies.
No.
Only about 10 or 15% of patients who you suspected of adenomyosis who are having a bad time of trying to get pregnant were getting pregnant in those 2-month studies. They suggested even in the patients who were suppressed for 3 years with Lupron that it would helped a little bit, but not a large amount. So yeah, it's a really tough one.
And one of the questions that were brought up by the reviewers was that the potential adverse effect on keeping people for a very extended period of time on suppression, because let's even say you gained a tiny bit on the side of embryo transfer. Meanwhile, you're wasting 6 months of reproductive life, and maybe the patient is, older, and, these 6 months are vital. So you're losing basically opportunity to actually trying to get pregnant while you're suppressing, which is really the reason why it's clearly proven that hormonal suppression does not help fertility in patients with adenomyosis or endometriosis. And, I know we're talking about adenomyosis today, but we need to say that also about endometriosis, because I don't think everybody knows that. I don't think every physician knows that either. They tell people, get on the pill for 6 months, you'll get pregnant after, you'll be better. Not true.
One of the other things that I came across when I was looking into it was the fact that 35 for patients with adenomyosis seemed to be almost like a bit of a wall as well. And you get past that 35 age, whereas, for conventional IVF, really, you don't start worrying about things until 38. But 35 with adenomyosis may be one of those ages that is even more critical for those patients. Correct. So what to do is still a dilemma. And, people sometimes come and ask me, say, because the fertility doctor recommends a Lupron, and I'm divided, because obviously we know that the studies don't tell anything, don't tell everything, and, insufficient evidence. And, we're always presented with the fact that even in endometriosis surgery, there isn't enough studies, and sometimes you have to go on a case-by-case basis. So I don't think there's a one answer for this type of medical treatment for prior to IVF. I think a lot of it depends on individual cases, and the care has to be tailored to the individual patient, unfortunately, because the data is just not there for adenomyosis and IVF. Yeah, with endo, we know that, with stage 4 disease, their fertility is probably less than 5%, and it is 10 times higher after surgery. Absolutely. And even higher with IVF. But we just can't expect anything like that with adenomyosis. Correct.
So it's a bit of a dilemma. It's a big dilemma, actually.
Yeah. So what are the differences between, very interesting conversation. What are the differences between diffuse adenomyosis and focal adenomyosis?
Okay. So focal adenomyosis is basically where you have a discrete collection, which usually creates almost like a little cystic foci of endo in the uterus. So you could have what's called an adenomyoma, or you can have a very localized area of adenomyosis as well. And so what you can do is, if you do have a more discrete adenomyoma, it kind of looks like a fibroid on, can sometimes be confused for a fibroid on an ultrasound, is you can go in and you can remove that adenomyoma, and you can definitely remove a cystic adenomyoma without any difficulty. With diffuse disease, it's kind of more widespread. So most of the posterior wall, or maybe the anterior wall, is involved with the disease. And so you're never going to really get rid of all of it. I have had some cases where I have removed adenomyomas, and I'm sure Dr. Vidali has had cases as well. They tend to be kind of the worst, most difficult things to remove, because unlike a fibroid, which has a very discrete capsule, adenomyomas do not, and they kind of irregularly merge with normal parts of the muscle, and it's really hard to find where the adenomyosis stops and the normal uterus begins. I did have one case where I removed almost 800 grams of an adenomyoma in a patient, and then she came back because she had recurrence of it, and I removed another 500 grams. And she got pregnant with twins, and she delivered one of those twins at 33 weeks. So for someone who had such massive adenomyosis, that's kind of like a huge success. Most of those patients wouldn't be getting pregnant. And so adenomyomas are a little bit easier to remove. They're a little more treatable than diffuse adenomyosis, but they're still very difficult to treat.
Yeah, I had focal adenomyosis, which actually Dr. Vidali removed. But it is if that's your situation and you're able to take that chance, and maybe it's not going to help everything, it can be a huge increase in quality of life, because your pain is directed at this one spot that then gets removed. But not everybody is so lucky to have that.
And there is something called cytoreductive surgery for more diffuse adenomyosis. And the first doctor kind of who described this was Dr. Asada, and it's called the Asada procedure. And there's a couple of different ways to do it, where you have like an overlying flap technique, or you can do what's called an H technique, where you basically remove a portion of the posterior wall of the uterus, trying to not enter the endometrium. And then you basically take out a big chunk of that, and then you kind of bring it back together. And, some studies have suggested that that's successful, a little bit more successful in getting pregnant in patients with severe adenomyosis. And we're usually talking patients who have uteruses that are, 3, 4, or 5 times bigger than normal. And those patients may be able to get pregnant. But again, not a lot of doctors do that procedure. I'm not sure if many do it robotically, or I don't know of anyone who does it laparoscopically. And so sometimes you may have to have that done through an open procedure.
I've personally done a few, but my experience with this operation, in my opinion, is that ultimately you're almost doing a hysterectomy and leaving like a shell of a uterus in a way.
Yeah.
That is just almost for show. You understand that? It's almost non-functional in the sense that you don't really have much muscle left. You have some muscle left, but not much. So
yeah, I always describe it as a dysfunctional uterus.
And so, really, yes, there could be an improvement in the symptom, but you're subjecting a patient to a much bigger operation. Ultimately, it's a non-functional uterus for all means and purposes, and in most cases, and there's issues of uterine ruptures or premature delivery. So at this point, although there's literature supporting it, I don't recommend really this procedure, unless somebody was very, very committed not to have a hysterectomy and to have, like I said, like really an impaired uterus to some degree. So I think that's really where it's at. So I agree with you 100% from that perspective. And
so this is our 5th year, but in our first year, we wanted a panel on adenomyosis, and there is a guy, I believe he's in St. Louis, that was doing a great deal of OSADA,
and had
trained.
Yeah.
And so I call him up, we don't even have a logo at that point. And he was like, didn't understand what I wanted, because I wanted him to come to the endometriosis summit. And then in the end, after 2 or 3 phone calls, when finally he got who I was, he said that he really doesn't do them anymore, because he wasn't seeing, for the amount of damage that you do to the soft tissue and to everything else, he wasn't seeing any results.
Yeah. And I think that even, where it's maybe done a little bit more commonly, in Japan or some other Asian countries, I don't think the results are, what the initial first study suggested.
Yes. Okay. We got some great questions here. Let's talk about, age. Is adenomyosis a disease only for older women? Dr. Cianarvo?
According to this one paper that I saw, 20% are women under 35 or 40, and the majority of them are above 35 or 40. I think our idea that adenomyosis only affects women who've had multiple pregnancies, that kind of thing, is a little outdated. I've had patients in their teens with adenomyosis, and I think that maybe it was during this conference or another one last year that suggested that adenomyosis I think it might have been an AGL, maybe more commonly seen in teens and patients in their 20s and 30s than we ever expected. So I don't think it's just a disease of women in their 30s and 40s, but it does probably peak in that age range.
What you see in younger patients are people with severe dysmenorrhea with maybe minimal endometriosis, and then maybe it's the adenomyosis that's causing the symptom,
Yeah.
Especially in younger patients, like you see minimal endo, that's size, but the severe dysmenorrhea, which, until proven otherwise, it should be, adenomyosis should be considered a problem, instead of like idiopathic dysmenorrhea, which it's kind of a strange diagnosis. Not that it doesn't exist, but it's definitely, it should be, it's a rule out type of problem rather than a rule in.
Yeah, I actually just had a case today that young patient, maybe 18 or 19, they did an ultrasound, normal size uterus, but the uterus itself was heterogeneous, and they suspected adenomyosis based on her symptoms as well, like irregular bleeding and severe pain.
And what goes into that, especially with a young person, what goes into that conversation about hysterectomy for adenomyosis?
Well, that's always one of the more difficult things that we have to address. I find that one of the hardest things to do is a hysterectomy in a younger patient. They're usually the ones driving the conversation. I'd rather just try everything under the, that I can medically, and even try a presacral neurectomy in those patients who can have it before I kind of even bring that up. But for some patients, you have to go over, just kind of dealing with it and trying to manage their pain, look at alternative methods to try to manage pain, look at even like something like an InterStim device, which may be helpful in a small percentage of patients, maybe as much as 50% when you get down to that last step of an InterStim. And then you say, okay, well, this is what having a hysterectomy when you're young means, that you won't be able to carry your own children, but your quality of life, you've got probably, 90% chance that your quality of life will be better. Unfortunately, there's going to be a small group of those patients that still have pain for reasons we don't understand. I think the results of hysterectomy in older patients is definitely better, upwards of 95 to 98%, satisfaction in terms of quality of life when combined with complete excision of their disease. But sometimes in those younger patients, it's going to be more difficult. And that's usually something that the family kind of is, very involved in. And it's often the patients who's driving that decision as opposed to the doctor trying to push that option on them.
Dr. Vidali.
I pretty much agree with 100% of what Ken just said, that in our profession, we encounter these cases, and, whatever we do, our goal is to help people ultimately. And I think that's, and we do know that there is an increase, that you do these operations with the objective of increasing people's quality of life. Really, that's really where it's at. But sometimes these choices imply a trade-off, and which is a painful decision, and that's really what it's all about. But I think that Ken presented this dilemma very clearly, and we, all of us who do this type of work, are involved in these cases like this, because sometimes we're like the end of the line for many of these patients.
Yeah,
I think we have talked about there was some webinar, Dr. Vidali, where you were talking about at the end of the day, there is patient autonomy, and it's the choice, right? There's a difference between choice and having it pushed on you.
Oh yeah. And that's how I approach every patient. Again, it's not like I go through the list. Okay, you can do this, you can do this, you can do this. they've already done all that by the time they get to us. And then it's a matter of, okay, well, these are your options. I'm happy to help you out with any of those options, but ultimately it's up to you. Even when someone comes to me for surgery for endo, it's the same thing. I'm presenting them the options, and they're ultimately making the decision whether or not their symptoms are bad enough to warrant a surgery in the first place.
Now, is hysterectomy sort of definitive cure for adenomyosis, or can people have persistent pain driven from adenomyosis post-hysterectomy?
I think for the great majority of patients, again, 95 to 98% of patients, they're going to have significant improvement in their quality of life. There's always going to be some outliers there who have other causes of their pain that no matter what is done, they're going to still have some pain. And those are probably some patients who've got, typically I find that those are the patients who've had many, many surgeries by the time they get to us, like more than 10. So it's a small group of patients who've had that many surgeries by the time they get to us, but they're going to be harder to get their pain completely out of control or under control because they've probably got some retroperitoneal fibrosis or scarring under the surface that's contributing to their pain, or they may have central sensitization. One thing about central sensitization, I think that it's probably overused as a term these days by a lot of gynecologists because they get patients who have persistent pain after one ablation surgery, and then their doctors say, well, I treated your endo, so you must have central sensitization as the cause of your pain. When in reality, their endo wasn't completely or adequately treated in the first place most of the time. So that's the term that's sometimes thrown about these days that I really think is probably a lot smaller percentage than maybe kind of seen in the literature. And I think that patients with real central sensitization, they're not getting better. They won't get better after an excision surgery and a hysterectomy. But most of those patients do get better. So the number with central sensitization, I think, is a little bit exaggerated. But I think most patients do very well.
I think there is, we have Dr. Vidali, you talk for a second.
We just were talking about a hysterectomy, and I think perhaps people sometimes ask about a subtotal hysterectomy, leaving the cervix in place, which is probably not a great idea with people with adenomyosis. Would you like to expand on that, Ken?
Yeah. So one of the concerns about leaving a cervix in someone with adenomyosis is they may have adenomyosis in their cervix too. There are some patients in whom I have offered that, or the patient has really been adamant about requesting that. And I really only do it in a patient who's got minimal pain on examination when their cervix is examined. Okay. And so in those patients who've got like a 1 or 2 out of 10 when their cervix is palpated, do I even consider doing that? Otherwise, they'll be back within months or a few years. So
cervix out.
Really it's a very small percentage of patients. I think a supracervical hysterectomy or subtotal hysterectomy is otherwise a very good procedure in the appropriate patient. Mostly patients with menorrhagia who don't have any pain associated with their periods or less pain associated with their periods. I think it's an excellent procedure. Recovery is a lot faster. Anatomy is less distorted, no risk of dehiscence of the cuff, less risk of abscess postoperatively. So there's a lot of pluses about a supracervical hysterectomy. But in patients who have painful intercourse or very painful cervix, anything more than a 1 or 2 out of 10, I shouldn't keep it.
So we were talking about central sensitization, and we're going to really take a deep dive on the science of pain this weekend with Dr. Dupree. And I think that there's a big difference between centrally sensitized pain and pain that the brain recognizes. And I know that that's subtle in the language that I'm using, but central sensitization is a concept that the pain is driven by the brain. We can prove that in the presence of certainly endometriosis, that the brain has changes. That doesn't mean that the pain is only in the brain. I think it'll be very interesting this weekend. I wonder, do you see a decrease in the bloating that's associated with adenomyosis once the hysterectomy is done?
Yeah, I just much like endometriosis, I feel that there are probably inflammatory mediators that are released by an adenomyotic uterus. Patients often have, bladder irritability. They often have pain that may be referable to their bowel as well when they have a tender uterus sitting on the bowel. And, sometimes the only presenting symptom that these patients have had has been, painful bowel movements or constipation from a big adenomyotic uterus sitting on their bowel. And so I feel that sometimes, if you don't have as much pressure on the bowel, they may end up having less bloating. And definitely because the uterus is not there to release those inflammatory mediators, just like endo, I'd say probably 80% of patients have significant improvement in their bloating symptoms. Not everyone, because some of them do have underlying other, GI pathology like IBS or inflammatory bowel disease or celiac. So those things are going to also be around that are going to still affect a certain percentage of patients.
Also, if the uterus is heavier, or if you're a heavy bleeder, you're going to have pelvic floor spasms, which are going to contribute. And then they're going to remove the uterus, but no one's done anything about the muscular adaptations. Perhaps even, and I've seen it in young women, which to me is very sad. I've seen diastasis, which is a splitting of the abdominal wall from really involved adenomyosis. And then I think that that's so sad because we've not only trashed someone's quality of life, but also their body as well. Yeah.
Well, physical therapy, I'm not sure what percentage of my patients end up going to physical therapy, but it's probably like, 2/3,
Somebody is asking, does PT help with adeno? I'm going to be honest, I don't think it helps with adenomyosis directly. Does it help with the way your body has adapted to it? Yes, but your adenomyosis is still present while that's going on. So we have an interesting question. Have either of you heard about valproic acid to increase fertility in adenomyosis patients?
Not me. Ask the expert.
I haven't, but valproic acid, I'm pulling it up. I haven't, but something that I should definitely be looking at. One
of the ideas of how adenomyosis occurs and infertility in adenomyosis has to do with uterotubal dysmotility. So when you have adenomyosis, there's a disruption in the normal myometrial activity, and that the myometrial activity, specifically in the junctional zone, is what controls tubal motility. And if that is disrupted because of the adenomyosis, maybe being on, valproic acid is an anti-seizure medication, maybe it may have something to do with altering the motility of the uterus somehow, making it less, maybe regulating or kind of restoring the normal functional motility of the uterus, which may help. I'm not sure.
Yeah, I do see a study with 12 patients, a small study, in which they gave valproic acid for 3 months, and they see that after 3, but it's like I don't know, it's kind of like an old study out of 2010, so I haven't seen much of a growth, so maybe it was kind of like a fluky thing, but you never know. I'm always open-minded. I never roll my eyes, because there's always some possibility, but I don't know. I'm not confident.
One of my previous fellows, Zirak Khan, he did a study where they looked at bromocriptine in patients with adenomyosis as well. And they found that when they used 2.5 milligrams for a couple of weeks and then went up to 5 milligrams thereafter, about 2/3 of the patients had some improvement in their symptoms of adenomyosis. I'm not sure if that's been replicated anywhere else since then. Another thing that I sometimes use in those patients who we've exhausted all other options is danazol suppositories. So we have it made up in a suppository form. They insert the suppositories vaginally, just like it might help rectovaginal disease for endometriosis. It might help uterine disease because it's in closer proximity to it. So that might be something that could be used. I use usually 200 milligram suppositories. It's one of those things that, you know, you throw a Hail Mary just to see if it works in those patients who have failed everything else.
Ken, we're running out of time a little bit, but I would like you to expand a little bit on the principle, the concept of invasive adenomyosis, because we know that there's different types, you know, even in the world of, you know, in the appearance of endometriosis, there are patients who have this condition described as invasive adenomyosis, which is like adenomyosis that comes out of the uterus and invades, especially in the rectovaginal area. And it's kind of like the thing, what came first, the chicken or the egg, right? What is the, you know, would you like to expand on that and your experience with that and what your thoughts are of the origin of that condition? Is it coming from the uterus into that rectovaginal space, or is it coming from, you know, rectal space, vaginal space into the uterus?
Well, you know, I looked at one study and it found that the tissue that is within the myometrium is very similar to endometriosis in that it has its own ability to produce estrogen, which normal native endometrium does not. And so that they found that the cytochrome P450 was elevated in those tissues, which it shouldn't be if it's just invaginated endometrium, right? And so if you go back to the original studies by Cullen, who was the first one to really describe adenomyosis in the first series back in the late 1890s, he described adenomyosis externa. And that is that sort of exact situation where you can either have it in the rectovaginal septum, or you may even be able to have it in between the bladder and the uterus in some sort of situations. And I think that is probably more likely to be of an endometriotic origin than of a strictly uterine origin. And so I think that's probably just a different manifestation of, you know, an endometriotic origin. And, you know, we don't know how endo happens necessarily. We've got ideas. I don't think retrograde menstruation is the main reason for, you know, the great majority of endo. And I think that whatever is happening embryologically and or genetically to activate the disease is what explains those lesions best.
And I don't have a very extensive, like formal data on this, but my impression is that this invasive adenomyosis that extends like in the rectovaginal or also extends out towards the parametria, I see it more often whenever I see this kind of extreme cases in Black people, Black patients. And I think it's because, also fibroids are more common in this population. And I think that maybe that's what, because there's a lot of fibrosis in this type of thing. Have you observed the same, do you have the same observation, Ken?
Yeah, absolutely. That and patients who have ascites, almost exclusively Black patients, African origin patients.
Yes.
Patients who have, hemothorax. Almost all the patients that we've seen have been of African descent.
Yes.
And so I think it comes down to the genetics of endometriosis. Endometriosis is just not one gene. It's on a spectrum. It's this huge variety of disease that's largely genetically driven. And those persons are destined to have that bad disease. And then there's other patients at the other end who'll never get that bad disease.
You're muted.
Mute.
I'm muted because it was doggy hell for like a few minutes. I wonder, is it possible to have the very heavy bleeding but no pain with adenomyosis, or is adenomyosis always a pain driver?
I think probably 90% of patients, 85-90% of patients with adenomyosis, if you look at the literature, usually have pain associated with it. Probably about 10 or 15% may not have a lot of pain associated with it. And so they could have, less painful bleeding as one of their presentations. They may kind of be in that group of patients that we call having dysfunctional uterine bleeding, which we usually associate with anovulation or not ovulating regularly. But, I think they may fall into that category we would otherwise describe as dysfunctional uterine bleeding, which means they don't have an obvious reason for the bleeding that they're having.
Dr. Vidali, any parting thoughts on things that might increase implantation for those with adenomyosis?
Look, ultimately, it's a difficult decision. And I think that you have to look at how many embryos you have. It has to be looked holistically. You can't just say there's one solution, okay? And I can tell you that as a sort of parting positive comment, that I've seen patients also sometimes with very extreme adenomyosis that it seemed like an impossible case, successfully carry a pregnancy and shock me, just by doing that. So I think there's a lot and I'm sure I see Ken's nodding. So it's not all bad news. I mean, I think people can do it. You can still do it. And I think that's, the note that I'd like to leave people with.
I never like to say to anyone, your chance of getting pregnant are zero.
Right. Right.
Because if you say that, you're going to look like an idiot to somebody.
Yeah.
So the other thing is, in those patients who have terrible adenomyosis, you do an egg retrieval and use a surrogate, with the partner's sperm, so they have their own embryos and use a surrogate. Is that an option for some of those patients who have really dismal chances otherwise? It's another option there.
I think when you talk about that option, and it is an option, you should people should be aware of what that really costs.
Oh, it's about $50,000. Yeah.
Yeah. Or more, depending on how hard
Also
it is.
to 120 probably.
Yeah.
Well, that's New York prices.
Yeah.
I think I've had a lot.
Exactly.
It doesn't mean don't choose quality of life, but make an educated. It doesn't mean you have to suffer either. Anyway, I think it's a tricky disease, adenomyosis. So Dr. Cernovo, you're one of the, I believe, pioneers in the field in sort of teaching us that adenomyosis, it's not just a fertility disease, it's a quality of life disease. Ahead of your talk this weekend, what do you think the burden of adenomyosis is on society? It's a little outside the surgeon realm, but go for it.
Well, you look at just the percentage of patients who have it. Okay. So 1 in 10 women have endometriosis, at least 20%. Some studies suggest that 39 to like 75% have adenomyosis. I don't think clinically it's that high, but then you've got patients who don't have endo and have adenomyosis as well. So you're probably talking about, 5 or 10% of women, which has pain impact on it. It has fertility impact on it. It has bleeding impact on it. And all of those things can affect, your productivity, and then your quality of life, and then your social activities and your psychological activities and well-being. So I think it's a huge burden, just as endometriosis is. And restoring quality of life, again, that's the primary thing that we aim for doing what we do. But I think that eventually, for most patients, we can definitely improve their quality of life and kind of restore all of those negative impacts, restore most of those patients, and sometimes help with fertility along the way.
Excellent. So the Endometriosis Summit is literally 3 days away. It is being held in person in Celebration, Florida, and virtually online. Virtual tickets can be bought even during the event. We're going to leave. You can virtually purchase anything. You can technically purchase in-person tickets. You just won't be able to eat anything because we're closing the catering. But virtual tickets are open. Dr. Cernovo, what are you looking forward to the most about the Endometriosis Summit?
I always like catching up with my colleagues, but I also love seeing some of the patients that are there. Often I run into a lot of my former patients, and I love that because I love seeing how they're doing, and most of them are doing extremely well. So that's always a very rewarding part of the experience. And really, I feel that the most important thing of the whole event is advocacy for patients, and the more and the wider spread that we can have advocating for our patients and patients or other people out there who are trying to learn about endometriosis. I think that that's the ultimate goal of that, so that ultimately we can change and get more people aware of their disease and understand their disease better and realize all the different options that they have for treatment.
Right.
And I'm bringing 100 of these pins, these endo pins, so that the first 99 people who want them can get them when they register.
Oh, isn't that nice?
That's from Cindy.
Oh my God. Also, I'm wearing my bracelet.
Oh, you got your bracelet.
I know, you're so lucky to have such an amazing wife in your corner. You know what I mean? She's just so supportive of you and of the community. I'm so grateful for her. Oh, that's so nice with the pins. Isn't that lovely? Okay. So, Dr. Vidali, 3 days away. What are you looking forward to the most?
I'd just like to make a comment and thank Ken, because I have to say we've done a lot of these, right? And I have to say Ken is a very kind and compassionate person, and this really comes across. And it just like really, it's honest and straightforward. And I think, I'd like to thank you for this, a really great evening today with you. And I'm excited to be there, Sally, because, it's, first of all, I'm excited to stop arguing with Sally, because as the summit comes to a close, the tension rises, the pressures rises. And although Sally and I are, I want to say, wonderful friends besides co-workers, sometimes things on both sides, I also take responsibility, but I know that after it's over, we're all going to be very chilled and very happy.
I think you're looking forward to the fourth day of the summit. Which is Monday.
Fourth day of the summit's at Animal Kingdom. So of course I'm looking forward to the fourth day of the
exactly.
summit.
Hopefully Animal Kingdom's not at the summit.
Yes.
Right. No giraffes at the summit. Alligators, though.
Oh yeah, Gatorland.
We have Gator World right there at the Nicholson Center.
Fantastic.
Yeah. I am looking forward to, I spent about 6 hours building our video library that goes in the virtual platform. So everybody will have access to some really interesting endometriosis information, and the in-person attendees also get that app. So that should be really, really fun. We're leaving tomorrow. So we have to drive up, and then I'm going to build our sets and see what we're going to do from there. So if you're interested in attending, please head to our website, theendometriosissummit.com, and you can find information there and sign up. If you want to see the full program, it is in our CVent. So you can click the link to register and see our full program. Otherwise, I'll see you guys this weekend. Now, you guys are going to log off because you have been operating all day long. There are some questions that I'm going to stay and answer whoever wants to hang around. But thank you very much, doctors.
Thank you.
Thank you,
Sally.
Appreciate you both.
Thank you, Ken.